So let's go through the contents of this PAL session. So we're going to be talking about the bodily fluid compartments and their constituents, fluid movement and osmosis, the measurements of bodily fluids, different types of IVs, most importantly, the Dorionic diagrams, which is what we're going to be getting most of our questions from, and finally, edema. So now just to orient ourselves a little bit, we know that 60% of our body weight is water. Now, of that 60%, 2/3 is in the intracellular fluid and 1/3 is in the extracellular fluid. Now, the intracellular fluid basically is all the water and all the fluid that's inside of each of our cells. And the extracellular fluid is the extracellular fluid itself is split into 3 other compartments: the interstitial fluid, plasma, and the transcellular fluid. Okay, so if we said that 60% of our body weight is water, and 2/3 of that water is in the intracellular fluid, then we can say that 40% of our body weight is in the intracellular fluid. And if we said that 1/3 of that 60% is in the extracellular fluid, then we could say that 20% of our body weight is in the extracellular fluid. Now, this fluid and this water is free to move throughout, in and out of each of these compartments, separated by barriers. Now, take a look at these dotted lines. What do you guys think they represent? All right, I guess
membranes.
Yeah, exactly, the membranes. So the cell membrane is what separates the intracellular fluid from the extracellular fluid, and the capillary membrane is what separates the interstitial fluid from the plasma. Now, as we know from CVP, the forces that govern fluid movement through the capillary membrane is known as the Starling forces. Now, but the forces that govern fluid movement throughout the entire body, in and out of every single fluid compartment, is known as the osmotic pressure, and we'll be going into what osmotic pressure is soon. But what I want you guys to know right now is that these osmotic pressures are governed by solutes that are dissolved in each of these compartments. So let's talk a little bit about these solutes. In the intracellular fluid, the major cation is potassium, the major anion is PO4 and other organic anions. The constituents of extracellular fluid, the major cation we have is sodium, and the major anion we have is chloride. Now let's talk a little bit about osmosis. So water can flow freely between different fluid compartments in the body. Osmotic pressure plays a significant role in determining water movement within the body, and osmosis is driven by the concentration gradients across the semipermeable membrane. Water moves from an area of lower osmotic pressure, which is higher water concentration, in other words, hypoosmotic or hypotonic, to an area of higher osmotic pressure, which is lower water concentration, in other words, hypertonic or hyperosmotic, to equalize the concentrations on both sides of the membrane. Now, osmotic pressure is based on the number or amount of solute particles dissolved in a solution, regardless of the size of the particles. The concentration of solute particles determines this osmotic pressure, with higher solute concentrations resulting in higher osmotic pressures. Now, what I want you to keep in mind is that although the osmotic forces will always want to correct any low or any high osmotic pressures in the body, they're not always able to do so. But what they are always able to do is that they're always able to equalize the osmolalities between 2 different compartments. So that leads me to the next slide, which is osmotic pressures and driving forces. The osmotic pressure of a solution is directly proportional to the concentration of non-diffusible molecules in the solution. So at a normal body temperature, the concentration of 1 osmol per liter results in an osmotic pressure of 19,300 millimeters of mercury in that solution. For each 1 milliosmol concentration gradient across the cell membrane, 19.3 millimeters of mercury osmotic pressure is exerted. And from that statement, we could derive the following formula, which is osmotic pressure equals to 19.3 times delta, or the difference of osmolality between 2 different fluid compartments. Now, let's just go over a summary of what I talked about, because I get that it could be a lot. So we have 3 different cells, each dissolved in 3 different solutions of 3 different tonicities. The first solution is an isotonic solution. So because what I mentioned here is that the osmotic pressure is equal to 19.3 times delta osmolality. Because in the first solution, we have no difference in osmolality, the osmotic pressure will be 0. And thus we would have no net movement either in nor out of the cell. In the second solution, we have a hypotonic solution, which means that the water concentration in the extracellular fluid is higher than the water concentration in the inside of the cell. In other words, we have a hypotonic solution, or a solution of low osmolality. That means that we'll see an inward movement, of water from the extracellular fluid to the intracellular fluid in order to equalize the osmolalities inside of between those two compartments. And then finally, in the third solution, we have a hypertonic solution, which means that the water concentration inside of the cell is higher than the water concentration outside of the cell. In other words, we have a hypertonic solution with a higher osmolality. That means that we have an outward movement. So the fluid would move from inside the cell to outside the cell, from the intracellular fluid to the extracellular fluid. Now let's talk a little bit about the measurements of the bodily fluids. Now this slide is basically just for memorization. So we have chromium-51 labeled red blood cells to measure blood volume. We have Evans blue dye, or T1824, bound to albumin, and radioactive iodine labeled protein in order to measure plasma volume. For the extracellular fluid volume, we have radioactive sodium. We have inulin, which is very, very important because that's where a lot of the questions will come from. We have inulin, and we have radioactive lethalimate to measure the extracellular fluid volume. And for the total body water, we have radioactive water and antipyrine. Now, for the intracellular fluid volume and the interstitial fluid, they're not measured, but they are actually calculated using other measurements of bodily fluids. So the intracellular fluid volume is actually the total body water, as the difference between the total body water and the extracellular fluid volume. And the interstitial fluid, being one of the three compartments that makes up the extracellular fluid, is approximately the difference between the extracellular fluid volume and the plasma volume. Now, I say approximately because you might remember we do also have the transcellular fluid, but the transcellular fluid only makes up about 5% of the extracellular fluid volume, meaning that just for our case, just for this equation, we could consider it negligible. Another way to measure blood volume is through the hematocrit. So if you guys remember from HLS, the hematocrit is actually the volume, or the ratio of the red blood cell volume to the total blood volume. And the total blood volume is the red blood cell volume plus the plasma volume. Now, if we derive that using a lot of math, which to be honest with you, I'm not looking forward to doing right now, we'll get the total blood volume, equals the plasma volume over 1 minus the hematocrit value. So now let's talk a little bit about IVs. So what I want you guys to focus on when we talk about IVs is specifically whether or not they're isotonic or hypotonic or hypertonic. Now I added the cases in which we use every single IV just for extra knowledge. You don't really need to know all that much about it. You just need to know whether it's isotonic or hypotonic or hypertonic. So first we have 5% dextrose solution, which is isotonic. It's for hydration without any electrolyte supplementation. Then we have Ringer's lactate solution, which is isotonic, and it's for trauma and burn patients with a similar composition to plasma in order to provide that electrolyte supplementation and in order to bring back electrolyte balance. Third, we have the saline solution, which is 0.9 sodium chloride. It's isotonic and it's for fluid replacement, or it's used during surgeries and procedures. Now, I want you to remember that 0.9% sodium chloride is isotonic. If we see an increase, so if we see, for example, 3% NaCl, that would be hypertonic. If we see 0.45, like the last case, then we would call it hypotonic. So the half saline solution, which is 0.45% sodium chloride, is hypotonic, and it's for patients suffering from hypernatremia. So just remember that half saline is hypotonic, 5% saline or 5% NaCl is hypertonic, and saline, normal saline, is 0.9%, and it is isotonic. And that leads me to the most important part of this lecture, which are the Dorionic diagrams. So this is what it is. This is what a Dorionic diagram is. It's basically just telling us where the majority of the fluid in the body is and how different cases would affect the osmolalities and the volume. So as we can see, any changes to the vertical dimension of this diagram would result in changes in osmolality, and any changes in horizontal dimension in this diagram would result in changes in volume. So there's 5 cases that we want to discuss when we talk about the Dorionic diagram. First one is loss of isotonic fluid. So when we have loss of isotonic fluid, the osmotic balance is maintained between the extracellular fluid and the intracellular fluid. So we have no net movement of water as delta osmolality equals to 0. So if we go back to this slide, we'll see that osmotic pressure equals to 19.3 times the difference in osmolality. But since we're only losing isotonic fluid, then we would have no difference in osmolality, and thus we would have no net movement of water in and out of any compartment. All we would see is a decrease in the volume of the extracellular fluid. So just to keep you guys oriented, the extracellular fluid is the smaller compartment, and the intracellular fluid is the larger compartment. So it's the one on the right, the extracellular fluid. So we would only see a decrease in volume in the extracellular fluid because we have no net movement of water. So the second case, which is infusion of isotonic fluid, is a very, very similar case. All that changed is the volume of the extracellular fluid increased instead of decreased. So as you guys can see, it's the same thing. Osmotic balance is still maintained between the extracellular fluid and the intracellular fluid, and we have no net movement of water as the delta osmolality equals to 0. The third case in the slides, if you actually read the doctor's slide himself, he called this case ingestion of salt tablets, but it means the same thing as saying infusion of hypertonic fluid. So infusion of hypertonic fluid, when we have an increase in extracellular fluid osmolality, water moves from the intracellular fluid to the extracellular fluid, leaving the intracellular fluid also hyperosmotic. So let's say, here's another case, for example, if we have 5% saline, which is, as I mentioned, hypertonic, produced in IV in a patient, then we'd have a higher osmolality in the extracellular fluid. Now, in order to balance the osmolality in between the intracellular fluid and the extracellular fluid, we have fluid moving from within the cell to outside the cell in order to maintain that balance. So when you have fluid moving from the ICF to the ECF, that also leaves the ICF also hyperosmotic. So what we see is an increase in the volume or the horizontal dimension in the extracellular fluid because we have that fluid moving from the ICF to the ECF. We have a decrease in volume in the ICF, as I mentioned, and we have an overall increase in osmolality because of that ingestion of a salt tablet or because of that 5% saline IV. The next case is loss of hypotonic fluid, such as sweat. For example, sweat is hypotonic. So what I want to mention is that osmolality of output fluid is opposite of the extracellular fluid osmolality. So for example, if we lose sweat, which is a hypotonic fluid, then our plasma would become hypertonic. And the same goes for urine. If we excrete a lot of hypotonic urine, we're left with hypertonic plasma. So in this case, when we're losing a lot of hypotonic fluid, the osmolality of our extracellular fluid would increase, and thus the water would move from the intracellular fluid to the extracellular fluid, and the osmolality would equalize. So this case is actually very, very similar to this case. So infusion of hypertonic fluid is very close to the loss of hypotonic fluid. The only difference, as you can see, is in the volume of the extracellular fluid. So when we have an infusion of hypertonic fluid, we see an increase in the volume of the extracellular fluid. But when we have, when we have a loss of hypotonic fluid, we see a decrease in the extracellular fluid volume. And the final case is the primary adrenal deficiency. So when we have a primary adrenal deficiency, that means that we have deficient or very reduced aldosterone, which means we have less salt reabsorption, meaning that we excrete more salts, and thus it leaves our extracellular fluid less with a lower osmolality. Now, this lower osmolality would result in water moving from the extracellular fluid to the intracellular fluid in order to maintain the osmotic balance between the two compartments. So let's talk a little bit about edema. So edema is abnormal accumulation of fluid in the interstitial spaces, which leads to swelling. The factors that can cause fluid accumulation in the interstitial fluids include increased capillary hydrostatic pressure, decreased plasma colloid osmotic pressure, increased capillary permeability, and finally, obstruction of lymphatic vessels. So the way I like to remember this is I think of hydrostatic pressure as a pushing pressure and the plasma colloid osmotic pressure as a pulling pressure. So if we have increased pushing pressure, or if we have increased capillary hydrostatic pressure, it means we're pushing fluid outside of the capillary, and thus that would cause edema. If we have decreased plasma colloid osmotic pressure, then we would have less pulling force from inside the capillary, which leads to more fluid accumulation in the interstitium. And then obviously increased capillary permeability and obstruction of lymphatic vessels would also cause edema. For safety factors, factors that would prevent edema, we have very low compliance of the interstitium. We have the ability of lymph flow to increase washdown of interstitial fluid protein concentration. So the total safety, so what I mean by the low compliance of the interstitium is that the total safety factor against edema is approximately 17 milligrams of mercury, meaning the capillary pressure and the peripheral tissue would need to rise by 17 millimeters of mercury before any edema could happen. So this sort of sums up this past session. Now let's get into some questions. A 23-year-old male runs a 10-kilometer race in July and loses 2 liters of fluid by sweating. He also drinks 2 liters of water during the race. Which of the following changes would you expect compared to normal after he absorbs the water and assuming osmotic equilibrium and no excretion of water or electrolytes? I can't really see the chat. Are we getting any answers?
No.
Okay. This one is a little bit difficult, so I get it. The answer is E. Now, as I mentioned, now this one's a bit of a hard one. So let's just go through it step by step. The way that we want to go through these questions, these cases, if I could just go to the Dorionic diagram. The way we like to go through these cases, we like to go through it as if we're going through a timeline. So in this example, if we have an infusion let's say, infusion of a hypertonic fluid, let's go through a step by step. Infusion of a hypertonic fluid, what does that do immediately to the extracellular fluid volume? It increases it. What does it also do? It increases the osmolality of it. So we have two things happening right away: increase in osmolality of the extracellular fluid and the increase in volume in the extracellular fluid. Now let's think of compensating mechanisms. What can we do in order to maintain osmotic balance between the ICF and the ECF now that we have an increase in osmolality in the ECF? So then we could say, okay, the water moves from the ICF to the ECF, and then the water, the ICF also becomes hyperosmotic, and then we have a decrease in volume in the ICF. So if we go back to this case, if we go back to the first question, let's go through a step by step. So he lost 2 liters of fluid by sweating. That means he's losing both fluid and electrolytes. Okay. Then he drank water to replenish the fluid that he lost, but he did not replenish the electrolytes. So that would leave a hypotonic extracellular fluid, and then the water would move because then the extracellular fluid becomes hypotonic. The water would move from the ECF into the ICF, which would decrease the ICF, which would then decrease its osmolality. The ECF is not able to completely bring its osmolality back, so it remains hypoosmolar. That's why we see an increase in intracellular volume in this question. We see an increase in intracellular volume. We have a decrease in intracellular osmolarity, a decrease in extracellular volume, and a decrease in extracellular osmolarity. Then for the next question, this one should be fairly easy. When 2 liters of each of the following clinical solutions are infused intravenously, which produces the greatest increase in extracellular fluid volume?
Someone said C.
No, it's not C. It's actually E. So option E is the only one that's hypertonic. So it would cause an increase in the extracellular fluid osmolality, which then would cause the water to flow into the extracellular fluid. All the other options are either isotonic or hypotonic to plasma. So if we just go back to this slide, infusion of a hypertonic fluid. So what we have is that this patient was, if I could just go back for a second. So what we have is a patient who was given 3% saline or 3% sodium chloride. As I mentioned, 0.9% is the isotonic. So anything above 0.9 would be hypertonic. So that case is very, very similar to this case in the Dorionic diagram. So we have 3% saline given to a patient. That would mean the osmolality and the volume of the extracellular fluid would increase. And then, so then we would have intracellular fluid moving from the ICF to the ECF in order to maintain that balance. So if we had, if C was the right answer, if we infused this patient with 0.45% sodium chloride, well, that's actually hypoosmotic. And what that would do is that would make water go from the ECF back into the to the ICF. So that would cause an increase in intracellular fluid volume and not extracellular fluid volume. Remember, we always go from the lower osmolality to the higher osmolality. Finally, which substances are best suited to measure interstitial fluid volume?
Someone saying C and someone saying
Sorry?
A. They're saying A. Yeah.
Okay. Well, it's actually not A, it's actually D. So as I mentioned, the interstitial fluid is not calculated, or sorry, it is calculated, but it's not measured using any direct method. So the interstitial fluid is equal to the difference between the extracellular fluid and the plasma. So inulin is used to measure the extracellular fluid volume, and albumin is used to measure the plasma volume. So as I mentioned, the most important one that we have, the most important measurement or method of measurement that we have for the extracellular fluid volume is the inulin, and for plasma volume, we have albumin. So if you take inulin and you do inulin minus albumin, or the measurements of both, then you would get the calculated volume of the interstitial fluid. So that sums it up for me. If you guys have any questions, please don't hesitate to text me or email me, anything, just let me know. Thank you so much.
Thank you, Rawad.
Thank you.
You're welcome, guys.